I am very pleased to welcome our Grand Round speaker today, one of our third-year residents, Dr. Heather Daigle. Dr. Daigle is a native Mainer and grew up in Fort Kent, Maine, and was a valedictorian of her class at the Fort Kent Community High School before going on to get her bachelor's degree in biology at Amherst College in Massachusetts. She then was awarded a Main Track scholarship and joined the Main Track Tufts class in 2014, graduating in 2018, and then joining our residency program. Dr. Daigle is an outstanding resident who's a wonderful clinician as well as teacher and patient advocate. If you look at her CV, she has given numerous talks to residents and medical students, as well as leading a variety of community efforts focused on advocacy for children. So Dr. Daigle, I think, is going into primary care, and the children of Maine will benefit. So her talk today is on somatic symptoms and related disorders, primarily pain. So thank you, Dr. Daigle.
Thank you, Dr. Tonolini, for that introduction. And thank you to all of our nurses. I just want to echo our gratitude to all of you. So thank you all for coming to my grand rounds. My title is We Feel Your Pain, Improving the Management of Somatic Symptom and Related Disorders. So I'm going to go ahead and get started. The CME code is right there for those of you who need it. I'll put it on my final slide as well, and we'll drop it in the chat box. I don't have any conflicts of interest, which is not surprising. So the objectives for this talk are, I hope to define somatic symptom and related disorders and review the scope of their impact on the healthcare system. I hope to review the current challenges in recognizing and diagnosing SSRDs, as I'll summarize them, the appropriate diagnostic workup, and dealing with diagnostic certainty versus uncertainty. I also hope to review some basic principles and ideas for treating and addressing SSRDs in the outpatient setting, as well as some basic principles and ideas for treating and addressing SSRDs in the inpatient setting. I wanted to start off with a couple of case examples. The first being a 16-year-old female who presented to the emergency department for persistent nausea and vomiting for the past 7 days. This is her third presentation to care in the past week and her 7th presentation for similar symptoms within the past 6 months. Workup so far has been unrevealing, and it's been fairly extensive. The second is an 8-year-old female who presents to the emergency department as well for persistent headache for the past several months. Her parents note she's been unable to attend school, and they're not leaving until they have answers. Workup so far has also been unrevealing, and it's included fairly extensive brain imaging. The last is the case that I saw in the emergency department, a 17-year-old male who presented to the ED for persistent testicular pain. This was his 4th presentation to care in the past 4 days, and workup so far at that point had included abdominal CT, scrotal ultrasound imaging, as well as consults to pediatric surgery and urology. It all had been unrevealing thus far. So what are somatic symptom and related disorders? I want to first start out by defining somatization, which is the process whereby distress is experienced as physical symptoms. So soma is from the Greek word meaning body, and I thought this was the most simple explanation for a complicated phenomenon. It's estimated to occur in 5 to 13% of pediatric inpatients and up to a third of pediatric outpatients. And it really becomes a disorder when it's impairing and meets specific criteria outlined by the DSM-5. So what is that criteria? So in order to have a somatic symptom disorder, you need to have one or more somatic symptoms. That part is pretty obvious. You also need to have excessive thoughts, feelings, or behaviors related to the somatic symptoms or other associated symptoms, such as excessive thoughts regarding the seriousness of symptoms, anxiety about them, excess time, energy devoted to them. The patient has to be persistently symptomatic, and so somatic symptoms can change over time. So it can be abdominal pain, nausea, headache, but the typical duration is 6 months in order to make the diagnosis. And there are certain qualifiers you can add on to it. It has to not be better explained by another mental disorder or physical health condition or another physical health health condition, and symptoms have to cause significant impairment and or distress, again, in order for it to be considered a disorder. And I thought that this graphic was a nice summary of what we're talking about. I think it's important to note that somatization can take really two forms. And so you'll often see us trying to categorize things in medicine as best as we can. And so on the left, we have somatic symptom disorder. And these are really disorders of body symptoms. So abdominal pain, headache, fatigue, nausea, chest pain. And on the right, you'll see we have conversion disorder, which is now known as functional neurological symptom disorder. And that's really your non-epileptiform seizures, your weakness, your unexplained paralysis, etc. And for the purposes of this talk and really general purposes of treatment and management, these two are really best grouped together in the sort of umbrella term of somatic symptom and related disorders. So I wanted to encourage audience participation. I know we're at that point where Zoom is getting kind of old. So I'll have several points throughout the talk where I'm going to use poll everywhere, and I greatly appreciate if people are able to participate. You can do that by going to pollev.com/hdaigle038 and joining that way, or you can text hdaigle038 to the number 37607. You just have to do that once to join, and then you'll be able to participate throughout the rest of the talk. So I'll give you a little time to do that. What I'm looking for here is, now that I've defined SSRDs, I wanted you to just brainstorm examples of things that you've seen in your subspecialty practice, in your primary care office, in the inpatient setting that would fall into this category of SSRDs. I'll just give it a little bit of time because I think it's worthwhile for future portions of the talk. Great. Functional abdominal pain, very common one. Pain in general. Joint pain, stomach aches, headaches. Great. Problems in school. Great. Chronic aches, myalgias, fatigue, vocal cord dysfunction, tics. Great. So I'll stop it there, but thanks to everyone for participating. So what you're describing and what you all entered in is typical to what's in the literature. So recurrent abdominal pain accounts for about 5% of pediatric office visits. So not a trivial amount. Headaches are reported to affect anywhere from 20 to 55% of all children. 10% of teenagers report frequent headaches, chest pain, nausea, and fatigue. And there is a sex disparity during adolescence that emerges, so 11% of girls versus 4% of boys, and this persists into adulthood. The rate seems to be highest among lower socioeconomic groups, and it seems to follow this developmental progression. So early on in early childhood, the symptoms seem to be predominantly abdominal pain. I think functional abdominal pain is something that we're all familiar with. And then in later childhood, it tends to be more headaches. In adolescence, it becomes more headaches plus nausea, fatigue, and more of the chest pain. So there have been studies, primarily classic twin studies, trying to figure out, is there a genetic predisposition to somatic complaints? And you know, there are studies as far back as what I could find in 1986, as well as a more recent one in 2016, that did find a higher rate of somatic symptoms or somatization in identical twins when compared to fraternal twins. They thought it was really related to these internalizing factors or traits. And so alexithymia, a difficulty in reading one's own emotions, trait anxiety, a continual tendency to react with anxiety, anxiety sensitivity, a fear of anxiety symptoms, and misinterpretation of their meaning. And interestingly, a smaller study, like I said, back in 1986, did also find a concordance in identical twins. There does seem to be some degree of genetic predisposition. But I really like this model that's located in a family handbook put out by British Columbia Children's Hospital. And it talks about how every person has some degree of biological vulnerability, and that degree varies. And so you can see on the left, there's a high degree of biological vulnerability and thus less room for stress before it overflows into somatic symptoms. On the right, you'll see biological vulnerability being, less for that individual, and so therefore more room for stress. So you have to be careful when we talk about how some people handle stress better. It's likely that some people just have more room for it before it bubbles over. So I want to take a minute to talk about the cost in terms of impact. So across all ages, according to a review in 2009, SSRDs actually account for nearly 20% of healthcare spending annually. So it's a large portion of healthcare spending, even though that's not pediatric specific data. I think it's still relevant. They account for approximately 15 to 20% of psychiatric consults in the pediatric hospital setting, and they've been reported as the second most common reason for consultation after suicide attempts. Also, that being said, primary or comorbid psychiatric conditions do result in a longer length of stay and therefore increased cost. And the same study that looked at that also found that the lead time to consulting psychiatry was also related. There was a positive correlation with longer length of stay and increased cost of hospitalization as well. And then you factor in that 18% of hospitalizations in freestanding children's hospitals within the United States include a mental health diagnosis. So we can extrapolate that there's a significant cost associated with this. I also think there's an impact that's more difficult to measure. And that's that when we do a poor job, or when we ourselves are not comfortable diagnosing SSRDs, we often focus with the families on what the diagnosis is not and what the diagnosis is, and we fail to give them a treatment. What we do is we actually risk alienating and marginalizing patients and families. And what happens, and I think we've all seen this in a variety of different ways, is that leads them to consult places like Dr. Google to explain their child's symptoms. And that can lead to some controversial medical diagnoses. And controversial medical diagnoses then can lead to potentially harmful medical treatments. I think in a lot of frustration when we encounter these families as to why that they're pursuing these controversial medical diagnoses or potentially harmful treatments for their children. I think one of the best examples of this, or one of many examples of this, is really chronic Lyme disease, where we obviously understand that children shouldn't be on chronic long-term antibiotics. But I think there are also many other areas where this comes about. And I think that, emerging sort of long COVID has the potential to become one of these. There's also an impact on healthy development. So as we all know, children should move through stages of development, increasingly becoming more independent, less reliant on their parents, having a bigger influence from their friends in the school system. But when they have somatization, what happens is they're ill, they're symptomatic, they rely more on their parents for their care, and they rely more on the medical system. And that pushes their friends and school and other activities out more towards the periphery. So certainly there can be impact long-term on their development. So who's at risk for SSRDs? So there are a variety of different factors. I thought this was a nice table just recently published in 2021, looking at a variety of studies, primarily of inpatients, and trying to identify risk factors for the development of SSRDs or somatization. What they found was several categories, including biologic and genetics. I already mentioned that abnormal somatosensory perception, that visceral hypersensitivity that we're becoming more aware and knowledgeable of. There are demographic features that I mentioned: female, white, adolescent age. There are certainly psychological factors, such as that internal coping style, but also perfectionism, as we've seen. There are psychiatric factors, so comorbid depression, anxiety, PTSD, and certainly history of trauma or ACE. A high ACE score can feed into that stress reaction. There are familial factors, so when the thought being that when a family doesn't recognize or put emphasis on emotional distress, then it can manifest as physical symptoms, and the family, when they're more apt to recognize those physical symptoms, then it feeds this perpetual cycle. And then you can imagine family history of SSRDs is also a risk factor, among many others. So what are the current challenges in recognizing and diagnosing SSRDs? So there's a group in Michigan consisting of psychologists, psychiatrists, pediatricians that recognize the high prevalence of SSRDs and the mismatch between providers' knowledge, comfort, et cetera, with in management of these diseases. And what they did was they conducted a needs-based assessment of providers, outpatient providers in the state of Michigan. They got about 80 participants in their survey. What I thought it might be interesting to do is actually go through a couple of the different categories that they surveyed their participants on as a group here and see how our answers might compare. So again, if you could join my poll everywhere if you haven't already. You can do that by going to polab.com/hdaigle038 or texting hdaigle038 to 37607. You just have to do that once, so if you've already done it. And the first question is really, how many times have you personally diagnosed SSRDs? And this is the formal diagnosis of SSRDs. So put it in the problem list, told the family that they have somatization, etc. And I'll give this just a little bit of time. Great, thank you for participating. So what they found in their study, which is not that different, although I think we did a little bit better than them, is that despite 100% of their participants saying that they had experience within their career of dealing with patients with SSRDs, they actually had a large percentage that responded they had never formally diagnosed it or rarely formally diagnosed it. So I thought that was pretty interesting. The next question, how many times have you personally talked with a family regarding their child's diagnosis and treatment of and prognosis for SSRDs? Again, being more of that formal discussion about what it is and how it's managed. Great. So there's certainly a skew towards never or rarely, but certainly we have some people with a lot of experience in this category. So what they found was that, again, a large portion, despite everyone having had experience, and actually up to 80% of those providers currently reporting managing a patient, at least one with SSRDs, they found that a good majority of them, over half, reported never or rarely having this discussion with families formally. So they also looked at most commonly encountered specific somatic complaints. And the top four are really what are echoed in the literature. So functional abdominal pain, chest pain, generalized fatigue, and headache. They also looked at provider perceptions of patients with SSRDs. And I think this was particularly interesting. So again, you can respond to this statement. I enjoy working with patients who have SSRDs. Strongly agree, agree, neutral, disagree, or strongly disagree. Great, thank you. So the answer that they got is not dissimilar to what I'm seeing. There was a large portion of providers, over a third, that also disagreed with this statement, and really less than a third who agreed. So that's pretty telling. I find that patients with SSRDs often cause me too much stress. All right, so we have over half in our group answering that they agree to this statement. And, comparably, they have a good portion in their group who answered either agree or strongly agree to that statement as well. I often don't know how to help patients with SSRDs. Yeah, so this one was a resounding over half in their group as well. And I think it's interesting that a very small portion really only disagreed or strongly disagreed with this statement. Additional medical diagnostic testing for patients with SSRDs is primarily driven by patient and family preferences or request. Yeah, so again, a resounding majority of their sample also agreed with this statement, while a small majority disagreed or strongly disagreed. A small minority, sorry, strongly disagreed or disagreed. Yeah. Patients with SSRDs require more time on average than my other patients. Someone's very quick to respond. I appreciate that. Yeah, I'm going to stop it there. And this one was the one that people agreed the most to, and I think that's sort of the nature of the situation. But the majority not only agreed, but really, if you look in their sample, no one disagreed, similar to our sample. Parents of children with or adolescents with SSRDs are more difficult to deal with than parents of patients presenting with other medical problems. Thanks. Yeah, and the majority of their group agreed with this statement as well, as you can see, over half. Patients with SSRDs tend to have comorbid mood or anxiety disorders. In the interest of time, I'll stop it there. But this was also a resounding agree in their sample, and only one of their providers disagreed with that sample, though, similar to us. Parents of children or adolescents with SSRDs tend to have mental health problems themselves. Great. And so their sample actually more strongly agreed with this statement. But as you can see, there was really no disagree or strongly disagree. I find that patients, and this is the last one I promise, I find that patients with SSRDs present me with interesting therapeutic challenges. So interestingly, in their sample, the majority of people agreed or strongly agreed with this. And you can look at our quick sample of 39% agreed or strongly agreed with this. So there's definitely an interest in managing and providing care for these patients. They also looked at provider comfort. So I found this part to be particularly interesting. So when it comes to diagnostic testing, the vast majority in their sample size reported that they were either comfortable or strongly agreed that they were comfortable with the diagnostic testing. When it came to the diagnosis, however, over a third were uncomfortable. When it came to the management, over a quarter. When it came to non-pharmacological treatment, over almost a quarter. When it came to pharmacological treatment, over a third were uncomfortable. And when it came to long-term prognosis in terms of discussing it with the family, again, over a third were uncomfortable. So there's certainly a lot of room for improvement there. They looked at provider practice patterns, and they found that over half, either sometimes, often, or always, or at least the majority, referred to a psychiatrist, similar to a psychologist or therapist. But they also found that when it comes to referring the patient to a medical subspecialist, the vast majority also sometimes, often, or always did that, in addition to other medical diagnostic testing. They looked at the management, including non-pharmacological management, and they found that the majority never or rarely provided written materials about the diagnosis. which is in contrast to what we try and do for other diagnoses in terms of adding things to the ABS. The vast majority reported sometimes or often having difficulty getting patients or parents to accept the diagnosis, as well as difficulty getting timely care from mental health and subspecialty providers, as well as finding mental health providers that are comfortable treating these patients. So what are the diagnostic challenges? I think I've reviewed some of the other challenges associated with SSRDs, but what are specifically the diagnostic challenges with SSRDs? So this is a table that I thought had a nice broad differential for pediatric somatization. And if you look, unrecognized physical disease, meaning disease that we have objective criteria for, that we can look at a lab or look at imaging, we have a treatment and a medication for it. So that's, the top of the differential. And then other unrecognized psychiatric disorders, so depression, anxiety, these are things that while some of the treatment is similar, there's a lot of differences in how we approach that. There's also factitious disorder and Munchausen by proxy syndrome. So this is very different. Patients are either faking or their parents are putting pressure on them. So this is managed very differently. They're not really experiencing those symptoms. Psychological factors affecting a medical condition as well. I think the thing that we're most worried about is this unrecognized physical disease, right? What if we're missing something? I think we can all think of examples of patients where we thought it was somatization and it turned out to be something else, and we felt awful because maybe we delayed treatment because we missed something. It doesn't help that over a third of patients who are diagnosed with functional neurological syndrome eventually end up with a neurological diagnosis, as well as, chronic epigastric pain can be H. pylori, chronic pelvic pain can end up being endometriosis, which is a diagnosis that takes a long time to make. So it's definitely at the top of our mind, I think. So how do we make the diagnosis? So Peds in Review had a nice article in 2011, a nice review, and it talked about how the diagnosis is really made over time and over 3 simultaneous tracks. And really the key here being simultaneous. So it involves ruling out an organic disease, but it also involves identifying psychosocial dysfunction and recognizing and alleviating stressors. So the evaluation itself should not be based only on a process of exclusion, which is, I think, how a lot of the times I've approached it. But how do we rule out an organic disease? I think this is something that we struggle with. So this is taken from that Peds in Review article in 2011. I think it's helpful to have a clinical consensus opinion when we're thinking about our approach. So they write, when the history and physical examination findings are suggestive of somatization, a basic lab screening consisting of a CBC, a SED rate, a CRP, a urine dipstick evaluation, sometimes a blood chemistry and alcohol blood stool test is sufficient. More extensive assessments should be reserved for the red flags. And I think we're all fairly comfortable with what those red flags look like. I think oftentimes, like we saw earlier, parents may be less comfortable with that limited evaluation, but we can feel comfortable knowing that this is the consensus opinion. And I also want to argue that, kind of going back to the basics of diagnosis in general, when I was in medical school, we learned a lot about likelihood ratios and Bayesian statistics, and how do we, make one item in our differential go up and another go down. And I think when it comes to SSRDs, what we tend to do is we tend to look for factors that make an alternate medical diagnosis less likely. We tend to do that until we've made them so far less likely that SSRDs becomes kind of a diagnosis of exclusion. But what the Peds in Review article suggests, as I talked about, is really also looking for factors that make SSRD diagnosis more likely as well. So things like multiple somatic complaints, a family history, lots of subspecialty involvement, lots of presentations to care, and those risk factors that I pointed to earlier. So I think it's important to really do diligence and really do come at this from both approaches. What I think happens, though, is I think there's this sort of perceived conundrum in these cases where you pick one path and that leads you down the right diagnosis and then, hence the right treatment. You pick the wrong path and that leads you down the wrong diagnosis and wrong treatment. And I argue that this is really not what we should be thinking of it as. So there's a nice way of looking at this in this family handbook put out by the British Columbia Children's Hospital, where they talk about the walking two paths approach. So the left being the known medical illnesses that we have, again, objective criteria for that we can diagnose and we have treatments, and the right being that mind-body connection and the fact that there's a degree, at least some degree of somatization. So what happens when we ignore that mind-body connection up front and we pursue that, medical illness, quote unquote, pathway first, is that oftentimes that can be a dead end. And now we have to backtrack before we go down that mind-body connection pathway. And it can actually delay patients getting better. So getting back to school, getting back to their peers, getting back to a functioning family unit. So I would argue going back down both at the same time, you actually save time and your patients are improving as you go along rather than waiting. And, if you do discover some underlying medical illness that you can treat with medications, et cetera, you're not harming the patient by going down this mind-body connection. In fact, there's also interplay between the two and some degree of somatization to any degree of medical illness. And so you've actually done the family a huge favor by going down both simultaneously. So now I want to move into treating and addressing SSRDs in the outpatient setting. So how can we do this? So I want to review some basic principles first. So standardizing care. So having an approach, understanding how to talk to families about this, having known treatments are very important and going about it in a very systematic way. And that involves increasing training of providers. So in that survey from Michigan, they found that 79% of those providers reported having little to no training in this area, despite it being so prevalent. And many of them who had training had read things entirely on their own. It's also important to address the perception of stigma. So there was a study in 2015 that aimed to look at the perception of stigma in these somatic disorders. And what they did is they tried to match what they called functional somatic symptoms disorders. So they matched IBS with other better known medical illnesses like IBD. So they matched IBS with IBD, they matched rheumatoid arthritis with fibromyalgia, and they matched MS with chronic fatigue syndrome. And what they found when they grouped the functional somatic symptom disorders together as compared to their controls, that there was a greater perception of stigma when they surveyed those patients. However, when they actually split them up, when they looked at the subgroup analyses, they found that the group with the chronic fatigue actually was the only one that there was a difference. And what they thought was that perhaps the diagnoses that were better recognized in the medical literature, like IBS and fibromyalgia, actually the stigma had gone a lot down. So it's important to think about that when we think about trying to reduce the perception of stigma with somatic complaints. It's important to formulate a treatment approach, so AKA have a plan. And I think this point is particularly important to dwell on for a couple of seconds. So my experience with patients with somatic symptoms is that, I was always surprised that when I'm delivering a diagnosis to the family in terms of what it's not, so I'm telling them their child doesn't have cancer, their child doesn't have, a serious autoimmune disease, their child that's going to require long-term treatment, their child doesn't have appendicitis that needs surgery, they seem not to be relieved. And, really was interesting to me. And what I didn't understand is the reason that they weren't relieved by that is actually because I'm telling them their child has something, or I'm telling them rather what their child doesn't have. And I'm not telling them what they have. And even if I'm telling them what they have, I'm not telling them how to treat it, right? Those other entities, we have treatments for. They may not be great treatments, but we have treatments. So it's really important that families are given a plan. And giving them a plan means that we have to know what that plan might entail, right? So we need to be able to talk about how hypnotherapy, CBT can be integrated. So I like this model because this is the British Columbia model, because I think it really goes through the nice treatment approach. So it talks about the initial confusion whenever we're talking about what's causing the symptoms. We're looking for medical conditions and mental health conditions aside from SSRDs. And it quickly moves into the connection, to the mind-body connection portion of it. So that's when you're providing a diagnosis, you're explaining it to the family, and you're creating a treatment plan. Then you move into those integrated treatments, and I'll talk more about that, but there's really a lot of back and forth, and these are very interrelated. And then the hope is that you get towards recovery, and these children do get better over time, most of them, and the goal of recovery is really to promote functioning and prevent relapses and promote resilience. And you'll see the arrows go back and forth because they move from recovery back to treatment and back to recovery. It's an ongoing process. So this confusion stage, I think it's important to understand where families are coming from, right? So their child is having these distressing symptoms, and there's a bit of a workup going on And they're concerned while that workup is going on about their child's overall health, their functioning. They're not sure if doctors are going to be able to find what's happening. They're going from doctor to doctor and test to test, and they're symptomatic, meaning that there's some degree of dysfunction. So I encourage you to really bring up the mind-body connection early on, because I think it lays the groundwork for really going down those two paths simultaneously, like I talked about. So the mind-body connection, right? We know that the mind and body are connected, and they work wonderfully together most of the time. So the hand senses a hot stove, the brain tells the hand to move, right? You're hungry, your brain tells your body to eat. You're fatigued, your brain tells your body to stop. But I really like this video that talks about what happens when things don't go so well.
This is called the mind-body connection. Let me explain the science behind that. The fight, flight, or freeze responses are a great example of the mind-body connection. When we sense that we are in danger, a very powerful physical response is triggered. This can happen anytime we feel really scared, like running into an angry animal or a soccer ball flying towards your face. Believe it or not, the same thing happens even when the stress we experience isn't life-threatening. The nervous system has two main parts, the sympathetic and the parasympathetic systems, which are always acting in balance. The sympathetic nervous system is like a gas pedal in a car. It tells your body to activate. The parasympathetic nervous system, on the other hand, is like the brakes in a car. It tells the body to slow down. The fight, flight, or freeze response is the sympathetic nervous system sounding the alarm. It all starts with your ears, eyes, and nose picking up a danger signal. Your brain makes sense of what's going on around you and decides what to do. Then it sends commands to your body using electrical and chemical signals. These signals tell your body to act now and to stay alert, to stay alive. Lungs breathe faster and shallower to take in more oxygen. The heart beats faster and harder, pushing the oxygen to your brain and big muscles so you can fight back or run away. Pupils dilate so you can see better. Hands and feet feel numb or tingly because your blood is being sent to other places in your body that are more important for survival. For the same reason, the stomach slows down because it doesn't need to digest food when your life is in danger. So when your brain senses danger, a whole bunch of bodily reactions happen quickly and without you even knowing it. Then, when the danger is gone, your parasympathetic system kicks in and tells your body to calm down, because even though these physical symptoms are not dangerous, they can be very powerful and problematic if they go on for too long. Often we aren't aware that our normal emotions can trigger physical responses in the same way as life-threatening danger. Daily stress from tests, the sadness of rejection, or feeling overwhelmed with responsibility are all very normal examples of emotions that can trigger a physical response through the mind-body connection. Sometimes the symptoms are caused by stress and emotions on their own. Other times, there is a medical condition as well, and stress and emotions make the symptoms stronger. Often treating these symptoms begins with learning about the mind-body connection. When we come to understand that the symptoms are real and powerful, but not dangerous, we can take steps to make things better. Like anything powerful, these symptoms can be overwhelming. But when we take the time to understand the mind-body connection, even though it can be tough, we can learn a lot about ourselves.
All right.
Well, kind of. I've been putting a lot of...
All right. So, I like that video because I think it really provides good language for us to be able to talk to families about this. I also, in talking with one of the corresponding authors, Dr. Colgren, a psychologist from Michigan, on the study that I showed earlier and another study I'll show in a little bit, one of the things that she gave us was an important example. So she talked about this being like a smoke alarm. And when the smoke alarm goes off or the fire alarm goes off, it's really difficult to tell if there's really a fire or if it's someone cooking too close to the stove, right? And so I think about my husband and I when we lived in Malden, Massachusetts while I was going to medical school. And when we first moved into a big apartment building, small one-bedroom apartment, the fire alarm went off in the building a lot. And at first we would go outside, we would get nervous. That was our secondhand furniture going to burn to the ground. And, it just took us a little bit of time to realize that every time it went off, there wasn't going to be a real fire. And it's really about making that connection for the families as well, and teaching the strategies on how to calm the body down, essentially. And so what are some of those integrated treatment strategies? As you can tell, you can approach this from many directions, and it's important to do that. But hypnotherapy is one of the areas that actually has had good evidence, particularly in functional abdominal pain or IBS. And so randomized controlled studies are hard to do with hypnotherapy. The control piece of it is challenging because it's very patient-led and patient individualized. And so this was actually a nice study that had 53 participants randomized to standard medical therapy, being 6 sessions of just supportive therapy over 3 months, as well as any sort of medical support, like PPIs, et cetera. And had 28 patients who were randomized to the hypnotherapy group. They received 6 sessions over 3 months with a clinician that had over 15 years of experience in hypnotherapy. They also received CDs that they could listen to on their own time, encouraged to do so on a daily basis. And what they found was pretty shocking given the small sample size. So all of these findings were not only statistically significant, but pretty strong in direction that hypnotherapy performed superiorly to standard medical therapy when it came to patients' pain intensity score, as you see, pain frequency score, as well as associated symptom score. And they saw that, interestingly, at 1 year follow-up, the hypnotherapy group, 85% were in clinical remission, and they had pretty strict criteria for what they considered clinical remission. The standard medical therapy, by comparison, only 25%. So that's pretty resounding. There have been attempts to do systematic reviews on this or meta-analyses. This is an example of one of those. It included only 3 studies, including the one that I showed earlier. Again, because of the challenge with hypnotherapy and the control portion of the RCTs, and they couldn't pull these results because they were too different in what they were measuring, but they did find that in all 3, hypnotherapy showed an improvement in patients' symptoms. So the other approach is cognitive behavioral therapy, and there's actually a lot of great data on this, particularly in adults. So this is a meta-analysis from 2019, actually, so recent, and it looked at 15 different RCTs, over 1,600 participants. What they found is that with cognitive behavioral therapy, there was a significant decrease in somatic symptoms, as well as depression and anxiety when you compared pre-treatment to post-treatment. And all of them had variable lengths of follow-up, but when they looked at the follow-up, they actually saw the same result, which is interesting. So I'm just going to show you, this is one example of a cognitive behavioral therapy workbook. It's titled Overcoming Functional Neurological Symptoms, but again, it actually talks a lot about some somatic symptoms as well. And they have this 5 areas approach, which I think is particularly interesting. So I put it up here for you to take a look at. The book itself is $30-something, so I did not purchase it, but I did get the opportunity. There's about 30 pages or so on Amazon that you can preview for free. And I would encourage you to take a look because I do think it has a nice layout for families. Certainly the ideal would be a therapist would be working on this with the family, and particularly families that are more older adolescents, high functioning, highly motivated families. It is aimed at a sort of a higher reading level. It's important to think about the path to recovery and review that with the families when you're talking about your treatment approach. So a typical recovery pathway is below, but the expected recovery pathway is at the top, right? So most people, when they're talking about recovering from something, they're hoping you're going to have linear progression until they get to the endpoint and stay there. But the typical recovery pathway is really more of this improvement, some relapses, some setbacks, more improvements, and eventually you get to where you want to be. But it's important that families know there are going to be setbacks. So now that I've talked about the outpatient setting, I want to quickly talk about treating and addressing SSRDs in the inpatient setting. So given the high prevalence of SSRDs, the American Academy for Child and Adolescent Psychiatry recognized the need for a clinical pathway in the inpatient setting. And so they put together a work group that came up with sort of a general pathway for all hospitals to, that could potentially be adapted to their hospital. And so I put that general pathway here. I'm not going to go into it in detail. I put it there so you can take a look at it at a later date. I'll make my slides public. But there's a group in Michigan, and there's a lot of overlap between these 2 groups, actually, as you'll notice with the authors, that had actually been working on and implementing a clinical practice guideline since 2015 in their children's hospital. And so what they did was, this group was actually born out of a journal club that was studying specifically somatization. So they were meeting once a month to talk about these patients and do literature reviews. And from memory, they actually came up with 36 patient charts selected to review. And those patients' age ranged from 8 to 17. There were 61% girls, 78% white. The most common chief complaints were neurologic, pain, gastrointestinal, and cardiopulmonary. And similar to here, they were admitted to different services. So the hospitalist service, neurology, gastroenterology being the majority, but also a smattering of other services. And this is just some patient and family factors that led into the patient's disease diagnosis and treatment, as well as some ways that the patient's disease diagnosis and treatment sort of affected the patient care team in the hospital. What they did is sort of interesting. So this is a value stream map. So they looked at from the patient arrived primarily in the emergency department for them, and I think that's probably similar to here, to the time they were discharged. What were some areas that really were kind of hiccups in the road? So this is a similar approach, I think, to our fishbone analyses. And I'm not going to go through this in detail, but I would encourage you to take a look at it if you do inpatient medicine, because I think there's a lot of overlap between what we see here and what they discovered at their own institution. So I went ahead and I made it a little bit bigger for you if you do go back and take a look at it. But again, I'm not going to dwell on it. They found some improvements that were needed. So there was certainly a lack of a standardized process. There was a lack of training of tools. There was certainly a large degree of lack of communication, both within the team and with the family. And so that led to a lot of areas that they found were wasteful, confusing, and led to an unsatisfactory experience for the family. And the family really noted poor care coordination, frustration, disappointment, etc. These were their key findings of their chart review of those 36 patients and the value stream map that came from it. I just want to point out, so a couple of things. The delay to mental health consultants was pretty common, whether that be family refusing early on or, the provider team just bringing it up kind of as a default diagnosis. And that certainly leads to longer length of stay. And that's what they found as well, long length of stays in these patients, absence of clear discharge plans. And then interestingly, even though this was a group of providers who came up with these 36 patients by memory, meaning that their hospitalizations were memorable for being SSRDs, there was really inconsistent documentation of the SSRD diagnosis at discharge. A lot of them ended up leaving the hospital without the diagnosis. So they came up with their own clinical practice guideline, which I've included here. Again, encourage you to look at it a little bit more closely in the future, but just some highlights of their guidelines. So when the patient is being seen in the emergency department, if they're going to be diagnosed from the ED, there's the idea of having some sort of handout that actually goes over the diagnosis with the family, and then a discharge criteria checklist, which I think is particularly interesting. If the patient is admitted, there's a separate handout that really sets clear expectations for the family regarding the admission and the goals of admission, particularly. And that handout, when they end up getting admitted, actually gets reviewed for a second time by the admitting team. And they actually are working on revising their handout at this time. So it's really more just over time we practice with providers and how to talk about this rather than actually having a physical handout. The idea is the same. Expectations are not that the patient is going to be cured when they leave. The goal is to do whatever evaluation remaining needs to be done and have them leave the hospital with a plan. The consults that they place, the core consults are placed early, and there's a strong emphasis on that. So they have psychology at their hospital, but child life, social work, etc., and then discussing any medical consult, any other medical consults that need to be involved early on as well, so that discharge planning can happen quickly. And they have, again, a list of discharge planning criteria. When the patients go home, they go home with that handout that they would get from the emergency department, explaining the diagnosis and talking about the treatment. So what are some ideas for, that being said, and again, I know I kind of glazed over that, but what are some ideas for improvement here at BDCH? So do we have room for our own clinical practice guideline? Is there a way that we can adapt our own handouts for families in the emergency department and on admission, with the goal of setting expectations early, getting those core consults, psychiatry, child life, social work, etc., involved early, and discharging with a plan? Again, I cannot emphasize again having a plan for these families because their children are symptomatic and they need a plan. Is there a way we can increase our residency training? So is there a way to talk about didactic sessions, how to talk to these families, how to use the appropriate language, how to have these difficult conversations? We actually have a difficult conversations OSCE. I think that it might be an idea to add this conversation to that OSCE or simulation. Is there a way to generate a resource list for families? So, there are a plethora of online resources that I had the opportunity to go through, including the British Columbia Children's Family Handbook. Is there a way we give that at discharge, or when they're leaving the emergency department, or we give it in the outpatient setting as well as a list of local therapists who are trained in cognitive behavioral therapy or hypnosis specifically for SSRD. So I don't really have a general idea of how many therapists or who in the area is comfortable with this. But I think that would be helpful for families rather than trying to figure it out on their own through trial and error. Should we be adding definitely SSRD diagnosis to the problem list? I definitely think it's important to be clear about it. It increases the awareness and decreases the stigmatization like I talked about. And then is there a way we can increase the knowledge and awareness among all healthcare team members? So educational sessions for our nurses, PTs, OTs, et cetera, to ensure consistent messaging, but also keeping in mind that a lot of other people are spending more time at the bedside with these families, and it can be frustrating for them trying to figure out why this child who's quote unquote, sometimes viewed as not really sick, even though we know that they are and they're symptomatic, it can be frustrating for providers and it can lead to burnout. So I think it's important to have those sessions for other healthcare team members. So my key takeaways before I open it up to questions are that SSRDs are prevalent. The symptoms are both real and very distressing. It's important to consider the diagnosis early, just like you would with any other differential that you're building, and start treatment early. You're not going to go wrong, even if you find something else going on with the family or the patient. Outpatient management is key and really should be the mainstay of this, but it's multidisciplinary. Inpatient medicine should be standardized in order to set expectations early, obtain consults early, particularly those core consults, and develop a discharge plan. The emphasis again being on patients and families, they need a plan. It's not enough to tell them what their child doesn't have. You really have to focus on letting them know that we know what it is and we can fix it, or we can help fix it. So these are my references. And I'd like to thank not only all the people listed on the slide, but just everybody in general who's been wonderful in my time at Maine Medical Center for the past 5 years. And I'm going to open it up to questions. Kevin Stan says, we have so much SSRD and GI. We like to talk to families about SSRD at the very first visit as part of the differential. That's awesome. It seems to give families permission to think about the impact of the brain on symptoms or impact of anxiety, and after often some of the GI workup, we have place to go for symptom management. Helps with history taking often. What other provider side techniques in the literature helps patients with an ultimate SSRD diagnosis improve symptom and functional outcomes? Yeah, so that's great. I think it's so important to talk about it right away, because oftentimes I think what happens is it's on our differential up front and we round outside of the room and while we're in the hospital, or we keep it until the very last minute. And what happens with that is families then feel like they're being handed off to therapy, or they're being handed off to psychiatry, and we're kind of giving up on them. So really letting them know up front that there's at least potentially some element of it and what's going on with your child, if not having it explain everything. So in terms of provider side techniques in the literature to help patients with the diagnosis and improve their symptom and functional outcomes, I would say really knowing the resources available in the community, whether it be hypnotherapy, cognitive behavioral therapy, or both, and really talking directly, I think, with the therapist that's going to be helping with the patient. It helps when you have an embedded therapist because you can talk about, how you feel this is due to an SSRD, and that, that's what they really need treatment for. So I think great that you're doing it early. I think that's really a mainstay. And then the multidisciplinary approach.
Heather, this was just an outstanding talk, and I think the issue that you chose affects people in every area of pediatrics. And so I think the recommendations that you provided are great for both inpatient and outpatient. And I just wanted to put in a plug in terms of hypnosis that Eileen Poulin, who I know was one of your mentors on this, is doing hypnosis through the primary care pediatric clinic at MMP. So.
Yeah, Dr. Poulin was great. And, it's tough following her talk last week which was so wonderful. But really an emphasis on just that mind-body connection. So hypnosis is one of the ways to get at that, and really calming down the sympathetic system, and learning how to activate the parasympathetic system.
And we've been working with Dr. Gerwin to advocate for either a psychologist or a psychological social worker to assist her in working with patients as well as parents and families to address some of these issues, as you mentioned, on the inpatient side.
That's wonderful. Are you able to see, I'm not sure if I can see all of the, oh, here's the chat. My chat is abbreviated.
I think I can go through the chat with you. Basically more comments than questions from Tom Reynolds. Love the durability of improvement after hypnosis, similar findings in habit reversal therapy for tics and Tourette's. We need to find a way to increase the amount of providers who can do CBT or hypnosis. Carol Hubbard says, really great talk, and I echo her. Really love the interactive components. And then I think this is from one of the social workers, perhaps at PSC, that she states that families might feel dismissed if we bypass some of the medical workup. But once they get to her for hypnosis, it's helpful to be able to say, now that everything can be done, should be done, has been done, we can move into these approaches and techniques. And I think, you know, what you said, Heather, about being able to provide a definitive diagnosis and have your group agree on that is really important to families, like coming to closure with the diagnostic phase of caring for these patients. And then, you know, the positive side is that we can move on to effective treatment. And then she's
just a comment on that, sorry. I think that, you know, we're in medicine, we're always going to have things in our differential that are going to be unlikely, but we can never fully pursue a differential until we've ruled out every single thing. And I think that we have to remind ourselves that these are diagnoses that get made over time, so that 6-month time period, right? And there's always room for going back and doing more of a workup should new symptoms emerge. And so just helping families understand that yes, part of it is reassurance, but part of it is, you know, we're here. The reassurance is that we are here and we will reevaluate on a continual basis. You know, the medical community is not abandoning them. It's the medical community working with the therapist, working with the social work too. So, I think we have to be careful not to beat everything to death in terms of searching for some other explanation before we send to therapy.
Yeah, and I think one last comment, Julia Fritz says also that she thought this was a great talk and wants us all to remember that the mind-body connection can play a role in symptoms in any diagnosis, and that there's a significant overlap of IBS and IBD.
Yes, definitely. And that's why, you know, going down that path early on, you're not doing any harm. You're actually doing a huge deal of benefit to the family by going down that path early, because you're going to augment symptoms, even if you do find, you know, an explanation for the symptoms in some sense, right? A more objective finding, a more objective medical illness. That's a great point. Thanks, Mary, for doing that. All right.
Thanks everyone for attending.
Thank you.